Chapter 29, Disorders of Gastrointestinal Function. Please note that there are several YouTube videos that go into disease processes in a good 3 to 5 minute span that are posted that you should be reviewing. Celiac disease, Crohn's disease, irritable bowel, colitis, GERD, peptic ulcer, peritonitis, pancreatitis, and hepatitis. This is just going to present a very high-level overview of bowel diseases or GI diseases. The job of the bowel is to digest food and make sure none of that corrosive stuff that helps us digest food gets out into the abdominal cavity, and to keep the food or the solution of digested food moving down the bowel at the right rate for digestion and absorption. The disease processes of the GI tract either impact the movement, the rate, or the ability to absorb and break down food in the pathway. When we talk about inflammation and damage to the bowel wall, we talk about it in terms of four levels. We can have hemorrhage, and we see hemorrhage in terms of a sign and symptom of anemia. We can have perforation, which means there's some sort of a hole along the bowel, and that will lead to peritonitis because it lets all that corrosive substances that's supposed to be inside the gut to go outside into the abdominal cavity. We see inflammation that creates a decreased mucosal function, resulting in malabsorption or malnutrition of the patient, and we see sepsis when the bacterial containment of the gut is let out into another area. It creates a sepsis situation. Know that the gut is very interlinked in its function, so a vicious circle can be created. One kind of bowel problem can cause another, and it's a very vicious circle. Also know that because the bowel is so interlinked here, when we see the end result of malabsorption, we don't necessarily know what part of the bowel isn't working because it's highly interlinked. So diagnostically, trying to figure out people with gut issues, what's going on, and treating their presenting complaint becomes highly dependent on history taking. It's usually a long and drawn out process, because so many other things can influence the bowel. If you don't know already, you will need to be more descriptive about vomit and poop than you ever thought possible. I'm sure you didn't think about this when you went into nursing, but when we start to analyze what comes out of the body, we can begin to get a clue of where the disease issues may be originating from. So if we have hemorrhage that's occurring above the stomach, usually we get frank blood, meaning I'm throwing up, hematemesis. It's blood. It looks like blood. It's red. It's, doesn't have anything else in it but blood. When we begin to see hemorrhage that is connected with the GI tract, particularly with the stomach, where there's partial digestion of that blood going on, you will see volitus that is coffee ground. So it will be clear with brown specks in it. When we see blood bleeding from the intestine, where the blood is actually mixing into the stools, you may not see anything at all. You may see occult blood, meaning if I tested your bowel movement, I could determine whether there was blood in there without the bowel movement looking wrong. Or I could have such large amounts of blood that's coming from my intestines that my bowel movements are a very, very, very dark brown, if not black. So the stool is no longer a brown color, it's more of a black color. I can also have hemorrhage occurring in the rectum, and that's more where the stool retains a brown coloring, but it has a red blood coating on the outside of it. Think of hemorrhoids. So the bleeding is occurring after the stool is formed, as opposed to as part of forming the stool with the occult blood in the melena. Several disorders of motility of the esophagus occur, which impact swallowing. They can be related to nerve innervation. That could be the glossopharyngeal nerve, the hypoglossal nerve, or the vagus nerve. We will talk more about dysphagia, difficulty in swallowing, as we move into learning about strokes. Those would be innervation problems. But dysphagia can occur as a result of a stricture. The signs and symptoms we see with dysphagia are choking upon eating or drinking, coughing upon eating or drinking. Achalasia is impaired relaxation of the lower esophageal sphincter. This creates a problem where food backs up and is more of a functional obstruction. And then we have gastroesophageal reflux disease, or GERD, where we have backing up of digested food through the esophagus, causing a burning because it's coming from the stomach with all the acids in it, creating a situation that we call heartburn. Biggest issue that we have with disorders of the esophagus are these all run the risk for aspiration into the lungs. Aspirating anything into the lungs other than air has a risk of creating a bacterial pneumonia. It's not a good thing. Hiatal hernia is a protrusion of the stomach through the esophageal hiatus of the diaphragm in a sliding motion. Think of this as an internal hernia. You know how you have a hernia that protrudes out in the inguinal area? This is happening internally. Again, GERD is the persistent reflux that's associated with a weak or incompetent esophageal sphincter. It creates irritation of esophageal mucosa. Generally, it occurs somewhere, the heartburn starts to occur somewhere 30 to 60 minutes after eating. It is absolutely aggravated by bending at the waist or lying down flat. It can be confused with chest pain or the way that women present chest pain. GERD is generally a very treatable disease. We give people antacids and proton pump inhibitors to minimize the pain and the reflux. We do lifestyle changes such as avoiding large meals, avoiding specific foods that create this same situation, not lying down for several hours after a meal, or keeping the head of the bed elevated at all times. Generally, obesity goes along with this diagnosis, so weight loss is known to be very helpful in decreasing GERD. We know that GERD occurs in children. It's very common between the ages of 0 to 6 months that babies spit up, particularly because of their small little tummies, and sometimes they eat too much. Generally, we see GERD resolving itself in kids somewhere between 9 months and 2 years. Mallory-Weiss Syndrome is a syndrome that is associated with chronic alcoholism. It results in a multitude of longitudinal lacerations and mucosal tears at the gastroesophageal junction. It is sometimes complicated by esophageal varices, which are basically hemorrhoids that occur because of the portal hypertension within the system and occur within the esophagus that can break open and bleed. Mallory-Weiss syndrome generally occurs after someone's been drinking and vomiting a lot, and then we start with hematoemesis because of these tears that have occurred because of that increased pressure. Several disorders of the stomach occur: acute gastritis and chronic gastritis. Think of those as non-hospitalized, unless you have some other disease process that makes you frail. We have peptic ulcer disease, and we have cancer of the stomach, which we won't go into. Gastritis is an inflammation of the gastric mucosa, generally related to NSAID use, could be related to a bacterial onset, which would be food poisoning, and that usually occurs within 5 hours of eating, and is very abrupt and a violent onset, and it's very self-limiting. Within 24 hours it's done. Gastritis can also occur because of irritation of chronic alcoholism, and it can also happen because of infection with H. pylori or Helicobacter pylori. Gastritis can have no signs and symptoms to, severe heartburn, pain, and vomiting. Treatment is usually palliative. We treat the dehydration and the pain. We give antibiotics and a protein pump inhibitor if H. pylori is the culprit, but generally these are self-limiting diseases. Peptic ulcer disease in my day, we thought it was more related to high stress type A people. We now know that that peptic ulcer disease occurs because of infection of H. pylori as the major reason, and NSAID use as the secondary reason. Signs and symptoms are characterized by remissions and exacerbations. You may have some hematoemesis and melena, lots of stomach pain. In order to diagnose this, we start with an H&H. Generally, if you have significant blood loss over a long period of time that you may or may not have noticed, your hemoglobin hematocrit will show a decrease. We test the stool for occult blood because sometimes you can't see it, but when we test for occult blood, it is there. We most definitely will be doing an upper GI and endoscopy to get a biopsy to know if H. pylori is the suspect. And while peptic ulcer disease is not life-threatening, some of the common complications that occur as a result of the body trying to fix this would be hemorrhage, perforation. The bowel perforates through all the muscle layers of the stomach, or obstruction, which can occur because of a spasm, because of edema built up, or because of scar tissue blocking the pylorus. So we want to take care of peptic ulcers sooner versus later so that we don't have any of these more significant complications. This is what H. pylori looks like. This is the frequency with which it occurs. On to the small and large intestines. Infectious enterocolitis basically is, again, the flu. Could be viral, could be bacterial. Irritable bowel syndrome is the catch-all disease and label that we give people when it doesn't fit into one of these other diseases of inflammatory bowel disease or diverticular disease, and appendicitis. In irritable bowel syndrome, we see that the gastrointestinal function is interrupted variably with a combination of chronic and recurrent intestinal symptoms that cannot be explained by a structure or a biochemical abnormality. The key symptoms that are seen are abdominal pain, and usually this abdominal pain is relieved by having a bowel movement. Another key symptom is that there are changes in the stool consistency and frequency. So that could mean more constipation, or it could be more diarrhea, or it could be a combination of both. But because of this disruption of the GI tract, there's abdominal pain, there's a gas buildup, bloating, nausea, and anorexia that occurs. Sometimes we figure out that there is a central nervous system dysregulation of the motor function of the bowel related to irritable bowel syndrome, and we can begin to use some medications to help with that regulation. But when we're trying to diagnose this, we're highly dependent upon patient history. We may ask patients to keep food logs to see if any particular foods created, if keep a diary that distinguishes what went on that day when you had constipation or you had the diarrhea. We generally send these people home telling them they need to do, biorhythm therapy and anxiety management, stress management techniques, avoiding fatty foods, gas-producing foods, caffeine, and alcohol. So we basically, take everything off the table and see what that can do. Sometimes the pain is so bad we may need to order antispasmodic and anticholinergic drugs to help with nutrient loss also. We also would need to test for food intolerances such as lactose or gluten. And we might also, or we will also test for intestinal parasites, whether they've been outside the country or not. So many people eat sushi nowadays, it could be from that. Crohn's disease is an inflammatory bowel disease that has no causative agent. It mainly affects the distal small intestine and the proximal colon, so it's up a little higher in the GI tract. We know that it is an autoimmune disease. We know that there is a familial link. So if someone in your family has Crohn's disease, you are more prone to be blessed with it. It is a disease that has frequent remissions and exacerbations of diarrhea, fecal urgency, and weight loss. In the GI tract, there are plaques of hardened materials representing a cobblestone appearance within the GI tract that are a hallmark of Crohn's disease. We know that Crohn's disease is particularly susceptible to intestinal obstruction, fistulas, strictures, and abscesses because of this specific inflammatory response that occurs. In terms of treatment, we take a nutrition focus. During acute flare-ups, we utilize steroids to calm the flare-ups. We do gut rest to make sure that the bowel can rest. These patients, when they end up in the hospital, are usually on TPN. And we may prescribe immunosuppressant drugs if the disease process is bad. Because of the intestinal obstructions and fistulas that occur, oftentimes people with Crohn's disease may end up with colostomies and such because large portions of their bowel are removed because of the disease process. Ulcerative colitis, again, another inflammatory bowel disease, also autoimmune, also family influenced. Same signs and symptoms, except there's rectal bleeding with ulcerative colitis. So the difference with ulcerative colitis is that the inflammatory condition that occurs within the mucosal lining is not granulomatous. It's a continuous application, so the entire lining of the GI tract from the colon to the rectum becomes irritated. There are pinpoint mucosal hemorrhages that occur and can become necrotic and ulcerate. Diagnostically, we treat both of these diseases the same. We will do a colonoscopy to take a look at what's going on up there, and we will do a biopsy to make sure that there's no cancerous agents at place. We know that during acute flare-ups, we try not to do these colonoscopies so that we don't risk perforation. But in the beginning, when we're trying to figure out what's going on, once we take a peek through that colonoscopy, we can see the differences in the internal mucosa and how it's protecting itself that leads to one diagnosis over the other. Diverticulitis is an old person's disease where the colon mucosa starts formulating little extra bags or sacs in the colon that shouldn't be there. Generally, this disease occurs in people that lack sufficient fiber in their diet, are not exercising at a regular rate and pace, and are over the age of 40 and under the age of 80. This can be a silent disease. This is one of the reasons why we do colonoscopies starting at age 50 something. We want to see if there is any diverticulitis in there. We can see this on an x-ray and on CT scan. Signs and symptoms include abdominal bloating, gas, change in bowel habits. So all of these diseases present the same, and we have to go in and take a history. Again, we need to treat this. Diverticulitis, if occurring, generally presents with a lower left quadrant pain that is accompanied by nausea and vomiting, a fever, and an elevated white blood cell count. Complications include perforation, peritonitis, and bowel obstruction, and we treat this by increasing fiber in the diet and doing our preventative diagnostics on a regular basis. Appendicitis would be a young person's disease. Think of this as happening as an inflammation or infection of the appendix, happens between the age of 20 to 30. It is an abrupt onset of pain around the belly button area, usually localizing to the right lower quadrant, accompanied with nausea and vomiting. The diagnostics that we see would be an elevated temp, increased white blood cells, consistent with infection. We would see, upon palpation of the abdomen, we would see rebound tenderness, and the treatment is surgery to get this out of the body before it perforates and creates a peritonitis situation. Enterocolitis, again, usually related to hypermotility of the intestines, having vomiting, foods not being absorbed, diarrhea, usually self-limiting, and we treat the symptoms and support the body until the infectious agent has left. This is just a description of what paralytic ileus or peritonitis might look like. We get a very board-like abdomen. We get shallow breathing. We get rebound tenderness and pain, and these are just common signs and symptoms of GI disorders that are getting progressively worse. As patients present to the hospital, diarrhea and constipation are not generally things that bring people in unless they have some sort of a secondary disease process. But bowel habits, bowel patterns are something that we should be looking at while they are in the hospital. Many of the treatments that we offer to patients create situations that either cause diarrhea or constipation, and we should be aware as nurses that these things are occurring and how we would deal with them to keep the patient in the best way we can. Again, intestinal obstruction. The interesting thing here is I want to point out how important, I know that we're kind of listening to bowel sounds now, but I don't know that the significance of bowel sounds is in your heads the way that it needs to be. So the absence of bowel sounds is always a bad thing. If I don't hear bowel sounds, it means that your normal processes are not working. I should always hear something. If I hear too much, then I would know that I had some sort of a mechanical issue, and it would be usually accompanied with some sort of severe colicky kind of pain and cramping. If I don't hear anything at all and I have pain, I'm looking at a paralysis issue or a board-like abdomen, which is never a good thing. So listening to bowel sounds seems trivial and trite, but it's really an important diagnostic part of our nursing assessment of patients within the hospital. Just some high-level overview of what happens when we get obstructions and the different kinds of obstructions that can occur. When we talk about alterations in intestinal absorption, the real disease process that we will talk about is celiac disease, which is a gluten intolerance, and that means wheat, barley, rye. We know that this is an autoimmune process that is mediated by T cells. We know there is a strong link between type 1 diabetics and celiac disease, as well as people with thyroid disorders and celiac disease. Signs and symptoms include diarrhea, abdominal distension, iron deficient anemia, and irritable bowel syndrome. So again, know that when you come in with GI disorders and complaints to your physician's office, there's a lot of history taking and deciphering that needs to go on in order to determine what is really happening. In the case of celiac disease, we would do some sort of an intestinal biopsy just to make sure that it isn't one of the other diseases that we've talked about. With celiac disease, we see high levels of IgA in the blood, and we treat celiac disease by diet alteration, eliminating glutens from